And so since they are diuretic resistant, I think the treatment would involve the withdrawal of the diuretics, administration of albumin, and drugs like terlipressin and octreotide can be used for these patients.
That's given very commonly
Yes,
nowadays.
and moving to the definitive treatment, I think liver transplantation would be the definitive treatment in such patients.
Yeah, that's in the end stage liver disease patients, but even otherwise, most of them, because the one good thing about HRS is that it is reversible. So it need not be in those patients, but even with chronic liver disease posted for something else, if the pathology is treated, many times the renal functions come back to normal within next few days or maybe a week. So,
yes, ma'am.
Okay, over to you, Supriya. We can move on with the next speaker.
Yeah, ma'am, we have one question relevant to this case. It's by Dr. Jessie, ma'am. Since the patient had massive blood loss and was on inotropic supports, post-op ventilation was not considered here, I guess. Patient was extubated on table.
Right. Now, pre-operatively, this patient was, except the fact that she was 70 years old, but she did not have any comorbidities. She had a midline incision. Okay. She responded very well on table. We already had more blood in waiting. I mean, it was already arriving. And she responded so well that even her noradrenaline and things like that, they all came down to no. I mean, we were hardly on 1 ml per hour when we shifted this patient. We had a good ABG. So we didn't think it was there was any indication at that point of time to continue ventilation as such. So because she came out well, we gave her the chance of extubation, keeping everything else ready. But we observed her for almost half an hour to 45 minutes in the OT, and then we shifted her to the, rather she was on sips of water by next morning, and she was sitting up as well. So that's the reason we decided not to put her on venti, because ventilator morbidities are again different. So being 70-year-old, if she's coming out, we thought it's better to extubate.
Very well managed, ma'am. Very well managed case by both you and Reva. So let's move on to the next patient. That is the most important topic. It is massive blood transfusion.
Supriya,
Yes,
there are a few more questions in the chat box.
Okay.
From Dr. Naresh,
okay, ma'am.
Liwal, sir.
Okay, ma'am. Okay, ma'am. So there is one more question: whether pre-operative embolization can be considered to reduce blood loss in such cases?
We had asked the surgeons actually. Now that is more of the surgical this thing that they should have. But they were like, there are too many feeders. It's a very huge mass. So wouldn't be much of help. That's what they told us. And they had to do it, go ahead, and they did the surgery. We did ask about embolization to them, including the unit head of that particular unit. But then they were not, and I think probably in the 2 days that she was going to get operated, the arrangements also were not made for the embolization. Plus, what they said is, seeing the CT picture, they said there are too many feeders and it's too vascular. So they were not in favor of waiting and getting it done.
As epidural was not considered as a mode of analgesia post-operatively also, any blocks were considered for pain relief?
There again, because it was a big, it was a midline incision, luckily not a rooftop. We could have given her tap or subcostal tap blocks, but surgeons said that, they wanted to infiltrate, and they didn't want to put even the incision catheter. I asked them if they could put the subcostal tap catheter. They were not in favor, considering infection and so much of, infusion of blood and so much of loss. So they were not in favor of putting the catheters also. So they gave infiltration. Yes.
Okay. Thank you so much, ma'am. Thank you so much. Let's move on to the next session, which is regarding the massive blood transfusion protocol. We come across this in our day-to-day practices in mostly obstetric anesthesia, trauma, orthopedics. So this will be presented by Dr. Shilpi Yadav. She is also assistant professor in D.Y. Patel Medical College. She did her MBBS in KMC Manipal with the DMD anesthesiology in Baby Memorial Hospital. With her teaching experience of 8 years and fellowship in regional anesthesia, she is working very hard in D.Y. Patel Medical College. Let's hand it over to Dr. Shilpi.
To present this interesting topic on massive transfusion protocol. Now, when we talk about the massive transfusion protocol, I think each anesthetist in their lifetime have faced this situation of massive blood loss. So once and all, we have started off this massive transfusion protocol. Now, I'll be covering my topics under these subheadings of definition, indications, development of massive transfusion protocol, preparation for massive transfusion protocol, trigger to activate and targets of massive transfusion protocol, the complications, and in the end, I'm going to discuss take-home message. Now, talking about the definition of massive transfusion protocol, it refers to the transfusion of large volume of blood products over a short period of time to a patient who has severe or uncontrolled hemorrhage. It can also be described as an empirical treatment that optimizes the management of resuscitation and correction of coagulopathy arising from severe hemorrhage. Now, we can divide the definition of massive transfusion in adults as well as in pediatrics. This I have taken from BGA 2013. In adults, it's a transfusion of more than 10 RBC units, which approximates the total blood volume of an average adult patient within 24 hours, or transfusion of 4 RBC units in 1 hour with anticipation of continued need for blood support, or replacement of 50% of the total blood volume by blood products within 3 hours. Now, when I talk about the definition in pediatric, it is Dive and colleagues who have defined the definition of massive transfusion in the pediatric population as the transfusion of 100% total blood volume within 24 hours, or transfusion support to replace the ongoing hemorrhage of 10% total blood volume per minute and replacement of 50% total blood volume by blood products within 3 hours. Now, when we talk about massive transfusion protocol, now why this is being designed? This is being designed to interrupt the lethal trial of death. Now, whenever there is a severe blood loss, there is coagulopathy, hypothermia, and acidosis. That is, there's increased lactic acid in blood, decreased coagulation, decreased heart performance. So when we decide this massive transfusion protocol, that has been designed to interrupt the trial. Now, what are the indications? The primary indication for massive transfusion is any situation which results in acute blood loss or hemodynamic instability. That can be due to bleeding, due to trauma, any ops catastrophe like postpartum hemorrhage, especially any surgery, especially cardiovascular surgeries, and GI bleeding. Now, when we talk about the development of massive transfusion protocol, this is a multidisciplinary team approach with minimum representatives from transfusion service, that is blood bank, emergency department, anesthesia, and trauma service. So basically, this is a team approach. Now, what are the challenges in the massive hemorrhage? When I talk about the challenges in the massive hemorrhage, the most important challenge is the time, because it is very important. The second challenge is the type of components to be administered and the selection of components. Now, when I talk about, there was a trial in PROM, there was a study in which they took 905 patients, in which they found out that early administration of high dose FFP and platelets in a ratio of 1:1:1, it reduces the early mortality. There was another study, proper trial, in which they randomized the 680 injured patients and they compare 1:1:1 to 1:1:2. Now, what they found out that there was a mortality at 24 hours was same between both the groups, but yes, 1:1:1 group, a higher percentage of patients achieved hemostasis, received less transfusions after the intervention, and received less frequency of cryoprecipitate. Platelet transfusion, it becomes necessary after 2 volumes of blood loss, 10 to 12 units of transfused RBC, it causes 50% fall in the platelet count. Hence, we should transfuse whenever there is blood loss Platelet concentrate should be transfused as 1 pack per 10 kg body weight. Cryoprecipitate, another important component that is again used to replace fibrinogen. It contains approximately 200 to 250 mg of fibrinogen per unit, and standard dose of 2 5-unit pools should be administered in major hemorrhage. Again, when you are transfusing cryoprecipitate, it should be guided by the fibrinogen results, aiming to keep the levels above 1.5 gram per liter. Now, talking about preparation of massive transfusion protocol, now that is very important. First, you need a large bore IV access. Then you need warming devices. You need continuous core temperature monitoring. You need invasive arterial blood pressure monitoring. You need adequate amount of blood and blood products such as PRBCs, FFP, platelets, colloids, crystalloids, infusion sets, and IV calcium preparations. You need adequate manpower and a teamwork. You need point of care testing, communication with the blood bank. You need rapid infusion pumps or pressure bags you need to speed the fluid infusion rate. Then definitely you need a good post-op intensive care. Now talking about the goals of transfusion. When I talk about the goals of transfusion, it can be divided into transfusion goals and it can be divided into hematological goals. Now transfusion goals are restore the circulating blood volume, arrest the bleeding, maintain oxygenation, tissue perfusion, and metabolic state. Now this is a massive transfusion template in which, if you can see, these are the transfusion goals in which you optimize the oxygenation, the cardiac output, the tissue perfusion, the metabolic state. And these are the hematological goals in which the temperature should be more than 35 degrees centigrade, the pH should be more than 7.2, base excess should be less than -6, lactate less than 4, calcium more than 1.1, platelets more than 50,000, PT, APTT less than 1.5 to normal, INR again less than or equal to 1.5, and fibrinogen more than 1 gram per liter. Now, what we have to monitor? We have to monitor full blood count, coagulation screen, ionized calcium, ABG every 30 to 60 minutes once we are starting off the massive transfusion protocol template. Now, this is a chart in which we show that whenever there is a massive blood loss, the initial management of bleeding has to be done mostly by the surgeon. They have to identify the cause. They can take the initial measures like compressions, tourniquet, packing, or they can do a surgical assessment like early surgery or angiography to stop the bleeding. Now, when I talk about the cell salvage, now this cell salvage, what is about it? That the use of cell salvage is wherever there is appropriate use, then only we have to use a cell salvage. It is useful in unanticipated blood loss and in patients with rare blood groups. It's even reserved for massive blood loss in OT, as asepsis can be maintained easily. Now, what are the dosages? If platelet counts is less than 50,000, one adult therapeutic dose. If INR is more than 1.5, it is FFP 15 ml per kg. If fibrinogen is less than 1 gram per liter, then cryoprecipitate 3 to 4 grams. And tranexamic acid, the loading dose 1 gram over 10 minutes, then infusion of 1 gram over 8 hours. Now, talking about tranexamic acid, these are the antifibrinolytic agents. Basically, they are useful in bleeding complicated by fibrinolysis surgeries like cardiac surgeries. And in trauma patient, it has been seen that if you administer the tranexamic acid early on, then definitely it can reduce the mortality. Now, talking about the resuscitation, it can avoid hypothermia. You should avoid excessive crystalloid. You should tolerate permissive hypotension and do not use hemoglobin alone as a transfusion trigger. Now, talking about the use of recombinant factor 7A. Now, the routine use of activated recombinant factor 7A is unclear. However, it has been used as a rescue therapy in patients with life-threatening bleeding, which are unresponsive to standard hemostatic therapy. So whenever we use as 200 microgram per kg, initially followed by a repeat dose of 100 microgram per kg at 1 hour and 3 hours respectively. Now, talking about the complications of massive blood transfusion. Now, before coming to the complications, I want to talk about the limitations of massive transfusion protocol. Now, first limitation is not standardized. That means every institution has their own protocol. So there is no guideline that yes, this is the guideline which has to be followed in every institution. The second is there's wastage of blood products. So sometimes your massive transfusion protocol template has been started off, but there is no transfusion. So there is a massive loss of, there is wastage of blood and blood products. So once we are sure that yes, there's a massive blood loss and we have to start the massive blood transfusion template, then only we should initiate it. Now, talking about the complications. Now, immediate before massive transfusion protocol is initiated, crystalloids in the ratio of 1.5:1 and colloids 1:1. The first complication is due to volume of resuscitation. Now, when I talk about volume of resuscitation, there can be inadequate resuscitation. It can lead to hypoperfusion, which can lead to lactic acidosis. Again, it can lead to reduction in thrombin and worsening the coagulation. Now, it can be overzealous resuscitation, which is a very most common complication which we see. And this is called transfusion associated circulatory overload, in which what happens that it is due to rapid transfusion of blood and blood products. So most commonly we see in elderly age group or in pediatric or in compromised left ventricular function. So in this, there is an increased hydrostatic pressure and decreased colloid oncotic pressure. So that can lead to abdominal compartment syndrome. Now, other complications, they can be a dilutional coagulopathy or interstitial edema. Then very known complications of massive blood transfusion are citrate toxicity, hyperkalemia, hypothermia, hypomagnesemia, acidosis. Late complications can be transfusion-related acute lung injury or due to contaminations. Now, when I talk about transfusion-related acute lung injury, that basically the risk increases with the number of allogenic blood and blood products. So I want to summarize my talk by telling that massive blood loss, you have to recognize it. You have to initiate the massive transfusion protocol early on, so that there's, the waste delivery time, the lag of delivery time is lessened. It's a multidisciplinary approach. There's a coordination of acute care physicians with blood bank officers and transport facilities. And each institution should develop its massive transfusion protocol customized to its available resources. Thank you so much.
Yeah, one question I had, Shilpi, is that you talked about cryoprecipitate. Now, do we need to give cryoprecipitate in every massive transfusion, in the sense, in particular situations you need to give, or you need to give cryo as a protocol in every case that we do?
Ma'am, basically cryoprecipitate, that basically we use in like wherever we are expecting massive blood loss, like massive trauma, or like in ops catastrophes like PPH and all, because this fibrinogen, that is like the first factor to go down. So to avoid the fluid overload, we don't usually, instead of FFP, this cryo, that is more preferred, resuscitation agent or blood product.
Where it's documented mainly fibrinogen levels going down. And like you rightly said, obstetric hemorrhage, the cryo needs to come in earlier, or very massive traumas that are got into the ER, they also require. Of course, for our case, we had time, she came up well. So it was not given in the initial phase. And we also talked about this MTP protocol being a multidisciplinary approach. So any role of these transfusion medicine specialists, now there's a new terminology, transfusion medicine. So transfusion medicine specialists, are they important?
Yes, ma'am, definitely they are important. Actually, in some premier institutes like Tata and all, they have started off this branch of transfusion medicine. And what is done that whenever there's a massive blood loss in operation theater, so the OT anesthetist or the circulating nurse, they actually give a call to this transfusion medicine specialist person. And this person, he comes to the OT and then he takes over the massive blood loss and he follows the massive blood loss template he does. So in that way, this is a teamwork, and the OT anesthetist, they can do their, they can more manage on the anesthesia part. And this transfusion medicine specialist, he can take over the massive blood transfusion.
They actually come to the OT and they become a part of this resuscitation, right?
True, ma'am.
Over to you, Supriya, unless there are any questions.
We are open for questions. A very good
was so
presentation.
good. Presentation was very good and complete, so there are no questions.
Yes, ma'am. Yes, ma'am. Everything was
Thank you,
covered
Rita.
very thoroughly.
Thank
Yeah,
you, ma'am.
absolutely.
1 minute.
Uh,
Yeah, just I want to ask uh, the the role of crystalloids and colloids in the is MTP. I mean, I didn't catch that. What's the
No, the role, sir, was that till your blood arrives, you need to keep the perfusion on. So that's where your crystalloids, you have to keep pushing till blood arrives. And so even if when we initiate a massive transfusion, it all depends, like Shilpi rightly put it. Some places the blood arrives in 10 minutes. Some
very
places it doesn't arrive even till 20 minutes. So
yeah,
till then, whatever
exactly.
you have, you're supposed to keep infusing. And
Okay.
so that is the role of crystalloids. But of course, once the blood volume is lost, it's blood for blood. So we have to replace it that way. But
We
when
should
it arrives, we have to give whatever we have. So,
seal and all that. We give in the meantime.
yes, sir.
Okay. Fine.
Thank you, Shilpi, and thank you, Rochna, ma'am.
Thank you. Thank you. Thank you for giving us this opportunity. Thank you.
Now I request Dr. Jayashree Lat to give vote of thanks. She did her PG from Nair Medical College, and now she is working in MCH Belapur.
Hello, am I audible?
Yes.
Yes, 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 yes.
Yes, yes. Thank you, Dr. Supriya. Good evening to all my seniors, my colleagues, and my all delegates attending the clinical meet today. First and foremost, I would like to give special thanks to Dr. Varsha ma'am, who is a GC member, Dr. Sureka ma'am, Dr. Vaswani ma'am, and Dr. Naresh Paliwal sir for their presence and giving their valuable time for attending this meet and encouraging us. I'm very thankful to our president, Dr. Jessie ma'am and Dr. Olvina ma'am for all their guidance right from the start of the announcement of this clinical meet, and all office bearers for all their efforts taken in organizing this clinical meet. I would like to thank Dr. Rochna Bakshi ma'am for being moderator in this clinical meet and upgrading our knowledge. A big thank you to all our speakers, Dr. Reva Shinde for wonderful case presentation, Dr. Shilpi Yadav for informative lecture on the blood transfusion, which we are dealing in day-to-day life, and Dr. Shri Arun for presentation on anesthetic implication in liver diseases. We are grateful towards all the Navi Mumbai ISA members and all our delegates for joining this webinar till the end and making this successful. Thank you. I want to thank you and big thanks to ISA Maharashtra State for providing the technical support and Zoenka for the same. Thank you so much. Over to you, Supriya.
I would like to give two reminders. Firstly, about the DY Patil PGCon, which is coming up in April. We will post the dates with the brochure. All PG students are reminded to please register. Secondly, just immediately following this at 8 o'clock, we have the Anesthesia Obstetric Association's lecture, which is very good. And this is a reminder for all of you to continue getting your knowledge. Thank you.
Thank you, Jessie ma'am.
Thank you, Jesse. It was wonderful. These meetings are super informative and very nice.
Thank you to the team.
Thank you,
Jayashree.
Thank you, ma'am. Thank you, ma'am.
I think we can all
Thank you,
call
ma'am.
it a happy evening. Okay. Good night, everybody.
Good night.